Thank you very much, Dr. Khanna, for inviting me to this grand conference, and thank you for such a generous introduction. I'm required to speak about the triplex scan, particularly for the peripheral arterial system. As all of us are aware, what is meant by triplex is that not only can you visualize the blood vessel on B-mode ultrasound, but also you can see the blood flow in it and the directionality of flow. And alongside, you can also evaluate the spectral waveform that the blood flow is producing. When all three can be seen together, real-time, live, that's called the triplex scan. I'm going to largely concentrate on interpretation because technique will require a completely separate didactic lecture demonstration. But if you'll allow me to proceed with a brief overview about the basics of the arterial scan. Why do the arterial scan, particularly for the extremities? Obviously, to answer the following questions, is there arterial disease, which means that are the symptoms produced by arterial disease? What is the anatomical location of the arterial disease? What are the characteristics? Is it a stenotic lesion? Is it atherosclerotic? Is it occlusive? Is it a thrombus? What is the severity of this? Are there multiple segments that are affected in tandem, perhaps parallel segments that are affected? And what sort of hemodynamic changes are produced on account of these occlusive or stenotic lesions? And finally, what is the treatment? I think most angiologists and vascular surgeons and vascular specialists would, if they're doing their own Dopplers, would be in a position to determine whether this patient qualifies for conservative treatment or for an intervention, either an endovascular or a surgical intervention. And these are the various pathologies that you can identify on triplex imaging: atherosclerosis, thromboembolism, arterial, aneurysmal disease, arteritis, vascular injury on account of trauma, entrapment, for instance, thoracic outlet obstructive entrapment syndromes or popliteal entrapment syndrome in the lower limb, and AV communications, either acquired, iatrogenic, or congenital. These are usually the probes that we use. This is a curvilinear array probe, which is about 5 megahertz. This is the linear array probe, which is about 12 megahertz. I don't have an image of the phased array probe, but this is the other one that I particularly like for the neck and for the upper limb, which is the hockey stick probe. In our case, this is a 13 megahertz probe meant for superficial structures. Now, when you insunnate blood vessels for the peripheral arterial system, remember there's some lines that you have to follow. This white line is, if you can follow my cursor, is called the Doppler line of sight. Now, that has to be aligned with the axis of flow of blood in the blood vessel so that the angle formed between the two is 60 degrees or less to get a proper spectral waveform. And these two lines, these black arrows, they denote what is known as the sample gate. Now, this is a very broad sample gate. You should have a narrow, small sample gate, which is preferably to be placed in the middle of the flow stream. Because of laminar flow, if you keep the sample gate close to one of the walls of the blood vessels, you might get an incorrect spectral waveform. And this is the spectral waveform that you get. Usually you might get one of the three. One is a triphasic spectral waveform. You could get a biphasic or a monophasic spectral waveform. Now, if you were to ask what I've depicted here and what I've labeled as biphasic and monophasic spectral waveform, is this a correct representation? You will find across the board various sonologists will be kind of arguing with each other. No, this is biphasic and this is monophasic. And there have been articles written about this, about the confusion that persists about whether a waveform is biphasic or monophasic, and should it be so difficult to characterize this in such a manner. And remember, I think you don't even need to look at the spectral waveform when you're talking about phasicity, triphasic, biphasic, or monophasic. It's such a simple thing. It's fundamentally referring to the sounds produced or the components of the sounds produced or the fluctuations in the Doppler frequency per heartbeat. If there are three components to the waveform, this is three sound components. This is triphasic. If there are two components, it's biphasic. If it's a single sound that you're hearing, it's monophasic. So remember, trust your ear. Don't even look at the waveform to begin with, because the ear is a highly sensitive spectrum analysis instrument. And if you're able to distinguish one voice from the other and identify the owner of the voice, it's quite clear that you'll be able to distinguish between the various phasicities of the waveform. So typically, these are representations of what is known as triphasic, three components to this waveform. and I'll talk about it a little later. This is biphasic, two components, various representations of what a biphasic waveform looks like. And this is monophasic, when there's just one component to the sound. Usually when you get monophasic, you're dealing with a problem. So this is what is triphasic. It's described as a swift upstroke of acceleration and deceleration during systole. Then there is a reversal of flow, if you can see my cursor, during earlier diastole, and subsequently there's antegrade flow in late diastole. If you can listen to this, I'm just going to play a clip. You can hear three components to the song, and I'm going to play the clip. So you could all hear the three components to the song. This is triphasic, this is normal phasicity for most extremities. And I'll now tell you why you get the reversal of flow in early diastole. Let's say you've kept your probe here on this part of the blood vessel. And this blood vessel leads to two branches which lead to high resistance areas. But proximal to this, where you've kept the probe, there is another branch coming off, which is going to a low resistance area. So in diastole, because downstream is high resistance, very briefly there is flow reversal towards area of low resistance. Therefore, if you keep a probe in this part of the arterial tree, there will be flow reversal which will be seen in early diastole. But if you keep the ultrasound probe on this vessel, which is directly leading to a low resistance area, there will be no flow reversal. And this is the reason why there is antegrade flow during late part of diastole. What happens fundamentally is that in systole, the compliance or the elasticity of the blood vessel stretches the blood vessel, and in diastole, this elastic recoil will further push blood forward, and this leads to the small forward flow during diastole. Similarly, if, as I have explained to you, because of if the resistance pattern in the vasculature decreases, so let's say you're warming the extremity or the person is exercising, because of that, there'll be vasodilatation in the muscles of the extremity, and his peripheral resistance will decrease. And you'll notice that a triphasic pattern will become biphasic. The downward reversal of flow component is eliminated because of decrease in peripheral resistance. So this is normal spectral waveform in a vessel where someone's just exercised or perhaps the extremity has been warmed. Similarly, when you're assessing the arterial tree for the upper limb AV access, if you ask the patient to clench their fist very, very tightly for about a minute and then release the fist, similar changes will occur. This is called reactive hyperemia. What happens is that for a minute when you clench it, there's transient ischemia. And when you release this, it leads to a decrease in peripheral resistance. And as you'll notice that the downturn, the reversal of flow here is eliminated in a triphasic pattern, subsequently becomes biphasic. This is also normal. I'll make you listen to biphasic flows. This is the carotid. This is again two components to the sound, which is normal for this because the carotid, the internal carotid supplies the brain, which is a spongy organ, and therefore there's virtually no peripheral resistance, and therefore there will be no flow reversal. This is a biphasic pattern, which is normal, and this is monophasic. This is tardus, parvus. Remember, tardus fundamentally means something that is slow to rise and slow to fall, and parvus is an attenuated or a flattened kind of peak, and this is usually indicative of an obstructive or a stenotic lesion proximal to where we've kept the ultrasound probe. This is what it sounds like. One component because it is monophasic. So I hope that is clear. And now I shall explain to you what happens in the peripheral arteries when it encounters an area of stenosis. Blood encounters an area of stenosis. This is fundamentally what happens. The area is narrow. Therefore, the first change you'll get is that there will be an increase in velocities because the same amount of blood has to be squeezed through a narrower orifice. Therefore, the velocities will increase. There will be what is known as spectral broadening. It will be a broad spectral waveform. Subsequently, there'll be filling of the spectral window. The spectral window is the black part that is seen under a wave. They'll be filled with all white stuff. And finally, if you keep the probe somewhere here, just distal to the area of stenosis, you'll get disturbed flow. And this is called blurring of the spectral margin. And also because blood flow is going in all directions because of the disturbance, there'll be some reversal of flow also noted. This is the same thing if you keep the sample gate and you take a sample from this area, you will find vastly raised velocities. This is the internal carotid, almost 300 plus flows, and you'll find the spectral broadening and filling of the spectral window. And if you just keep the sample just after the area of stenosis, because of the disturbance, this is blurring of the spectral margins and reversal of flow also noted. Remember, in the aorta, it might take more than almost a 50 to 60% reduction in luminal diameter or a 75% decrease in cross-sectional area to produce hemodynamic changes. In the iliac, it might be even more than that. So for instance, if there's a 50% increase in diameter, this is the kind of spectral waveform you get in the peripheries. You will find an increase in velocities, but the triphasic pattern does not change. It's only when the diameter is further reduced from 50 to 99%, that's when you get all the other changes. Of course, massively raised velocities, but the spectral broadening and the filling of the spectral window. Also, the peak systolic velocity ratios are important. So let's say at the area of stenosis, the peak systolic velocity is 2 times the peak systolic velocity just proximal in the normal segment. You're looking at a 50% luminal narrowing. If it's 3 times, you're looking at about a 65 to 70% luminal narrowing. And if it's 4 times, you're looking at a 75 to 80% luminal narrowing. And this is very briefly about the technique. This is how you insunnate the aorta. You start just below the xiphisternum. You can start with a transverse probe and then align it longitudinally. This is the superior mesenteric taking off from the aorta seen longitudinally. And this is just to the left of the umbilicus, the aortic bifurcation and the common iliacs taking off. This is some bleeding from the common iliac vein. And this is how you insunnate the lower limb. This is the common femoral and its bifurcation. And this is just at the adductor hiatus as the first part of the popliteal emerges. And these are some of the regions where you should keep the probe transverse and then align it longitudinally and then walk along the artery. This is below the knee, the infragellicular segment, and the tibials. Again, these are difficult to spot, but you should look for an artery with paired veins, and you should start off transversely, keeping the probe, and then align it longitudinally once you've localized the artery, and then walk along the vessel all the way down. Sometimes the peroneal and the anterior tibial can be difficult to insunnate because they're in between muscular compartments. This is when you keep the probe anterolaterally as the anterior tibial takes off and then walk along the artery downwards. This is for the upper limb. This is keeping this. I love using the hockey stick probe in these areas. This is for the innominate. This is the innominate artery, which is giving off the common carotid and the subclavian. This is subclavian first part. This is the infraclavicular axillary, or the first part of the axillary. This is the supraclavicular subclavian. This is the axillary artery in the axillary fold. This is what it looks like, clean long view, and this is for the upper limb. Again, the hockey stick probe works rather well, the radial, the ulnar, and the brachial. And once you've seen all this, you should be in a position to anatomically and physiologically decide what is to be done with this patient, and particularly anatomically decide upon the task classification of aortoiliac occlusive disease if you're insunating that segment, or the femoropopliteal occlusive disease. This is task classification for the femoropopliteal occlusive disease. And this is for the infrapopliteal segment, task 2 classification. And I'll very briefly, before I wind up, I'm going to show you some lesions as they look on ultrasound Doppler. This is the aortoiliac segment. This is a blocked, occluded infrarenal aorta, and you can see the thump, the monophasic thumping pattern seen just proximal to the blocked aorta. This is the occluded aortic segment, and you can see a stout collateral taking off from the occluded aorta. And this is the reformation on the right side, the common iliac artery, which is giving off the external iliac artery. This is on the left side, the reformed common iliac, which is giving the external and the internal iliac artery. This is a CT angiogram of the same patient, and this is the stout collateral that I was referring to. And when you do an angiogram, you can see the same stout collateral coming off and correlate the Doppler findings. This is the reformed right common iliac artery on the right side. This is the reformed left common iliac artery. And this is post-angioplasty with kissing stents. The aortoiliac segment has been completely reconstructed. This is an SFA occlusion. This is an occluded SFA. seen in the mid part of the SFA. You can see a collateral taking off exactly where the segment is occluded. And this is the reformed segment in the first part of the popliteal artery, which is seen, which is reformed. This is the Parvus Stardust flow pattern, collateralized flow pattern seen in the popliteal artery. And this is a CT angiogram of the same image. This is eminently reconstructible by endovascular interventions. So you can also decide whether this patient should be subjected to an endovascular therapy or an open surgical maneuver. This is thrombotic occlusion of the femoral artery. You can see a distended artery here, virtually no flow here, and again, just proximal to the occluded segment, a thumping pattern, monophasic, which suggests there's an acute cutoff subsequent to that. And this is again the collateralized flow seen, very, very low velocity, almost continuous collateralized flow seen in the distal in the first part of the popliteal, which means that there's virtually no collaterals, and this is an acute thrombotic occlusion you're dealing with. And finally, this is a popliteal stenosis, again amenable to endovascular treatment. You can see very, very tight stenosis, as is being established by aliasing of the color, and also this disturbance here, which is called the visible bruit, which means that you need to adjust the PRF, the pulse repetition frequency, when you're assessing this area because of the very, very tight stenosis and very turbulent flows. And these are the flows after this is after it's been, the PRF has been adjusted. You can see very high velocities with spectral broadening and filling of the spectral window. And this is the same thing which is seen on CT angio, again, eminently amenable to endovascular treatment. So with that, I'll finish my spiel on triplex scan. I thank you, Dr. Khanna, for this opportunity, and I'm happy to accept questions. Thank you.
Thank you very much, Ambarish. We can have questions now, or maybe after we finish Virendra's talk, so maybe both arterial and venous together. We have some questions in the question box. I think we'll have Virendra speak first, and then we'll have questions together, unless I'm holding you from your work.
No, that's fine. I'm happy to. Yeah.
So the next speaker would be Dr. Virendra Sharon, a very good interventional radiologist. He used to be working with us in Apollo earlier before he joined Medanta. And Virendra is going to be talking about peripheral venous disease, technique and interpretation of duplex scan in peripheral and venous disease.